All right, so we've talked about our risk factors, the screening. We've talked about how, like, what kinds of tests we do to screen. Let's talk a little bit about what kinds of manifestations you're going to see when we're talking about diabetes type 2. Not necessarily an acute manifestations like what we would see in hyperosmolar hypoglycemic syndrome or state or whatever, but what you're going to see just in the general progression of diabetes type 2. So remember that unlike diabetes type 1, the onset is quite gradual. If you remember, we looked over here, by the time diagnosis occurs, you've already been experiencing changes, I guess, in your body for somewhere up to 10 years. You may even have already started experiencing some minor cardiovascular symptoms. Maybe you feel a little bit more short of breath than you used to, but people usually chalk that stuff up to I'm getting older, whatever, and then they don't get checked out. It's unfortunate because if you get checked out here, you're much more likely to be able to reverse some of the damage and reverse some of the problems through diet and exercise and so on. So let's talk about these typical manifestations. Again, it's a gradual onset. Diabetes type 1 is usually a very sudden onset. Most people do not even know they have it. They might be very, very young, 6 or 7 years old, and you know, they get very, very sick. Parents bring them into emerge. I've had a few diabetic type 1 patients who came into emerge with DKA in their early 20s, but it hits suddenly. They are very, very sick. But these manifestations, again, you might go years with undetected hyperglycemia with very few symptoms because we don't have that total insulin depletion. The body doesn't revert to lipolysis and you don't have any ketones or acidosis. So whereas in type 1, you know, at some point the insulin would go so low, your body would start to break up that fat, and then you would get very, very sick because of all the ketones that are released and the acidosis that occurs. But because that doesn't happen in type 2, you just kind of keep getting sicker and sicker and sicker and sicker until hopefully you get help before you hit a hyperosmolar hyperglycemic state. So again, this is just saying what I just said. Symptoms are usually, so we're talking now symptoms of diabetes type 2 that is not HHS. We'll go through HHS very, very detailed in another video. But symptoms of diabetes type 2, again, kind of under the radar at first, fairly non-specific. You may have some of these 3 Ps that you get in type 1, the polyuria, polydipsia, polyphagia, but usually it won't be as bad. You're more likely to have this kind of fatigue, recurrent infections. So one of the big things is yeast infections. Yeast really, really loves high glycemic conditions. So very, very often people will have yeast infections. These kinds of infections are the more common, that will show up as like just recurrent, and people aren't really sure what's going on. They just kind of, you know, chalk it up to, you know, people get infections, not realizing that there's something more going on. Prolonged wound healing is an incredibly important manifestation for you to know and understand. When somebody has a diabetes type 2, we almost look at them as like almost immunocompromised and unable to kind of repair damage. So when someone is diabetic type 2, it's a good idea to keep them away from situations where they might get an infection that they may not be able to fight off. They don't fight off infection as well. But the big thing here, they have this prolonged wound healing. When the neuropathy mixes with this, there can be some very, very serious consequences. Visual acuity changes like blurred vision. Again, people just write it off. Peripheral neuropathy in the feet. This is actually one of the things that does bring people in to see their GP, because it's quite painful, and they start to think, okay, this is out of the norm. The lower extremity paresthesia, sometimes until it gets bad, patients don't necessarily come in. They just think, oh, my foot's falling asleep or whatever. So that's a really important thing to kind of know for a test. Know that these are signs of something more than just, oh, I have an infection. Or when you see all of these things together, or one or two of those together, that would be one of those people who, whether they are less than 40 or over 40, when they have these symptoms, they are at risk. They should be tested immediately, and then as long as those symptoms are continuing on, the textbook says every 6 to 12 months. So that's pretty intense. And then I just wanted to talk really, really quickly about these ABCs. These ABCs of kind of treating diabetes type 2. So A refers to your A1C target. Remember, we talked about hemoglobin A1C. We want to keep it at 7 or 6.5. 6.5, if somebody has a high risk of cardiovascular disease or retinopathy, we would like to keep it lower. It makes a big difference between 6.5 and 7. 7, again, that's your trigger time, right? Like if somebody came in for their very first test and they're at 7, that would indicate that they probably have diabetes or that their glycemic control is not good. So people who have diabetes type 2 are constantly having their blood work done every 3 months at least, and they do these A1C, and we want to keep them in this 7 to 6.5%. So that was the A. B, blood pressure targets. We want to keep it below 130/80. This is the official cutoff for hypertension now in Canada. If they're on treatment, assess for falls. That has to do with, hopefully you know this at this point, but when we're on treatment for hypertension, it often causes hypotension and often orthostatic hypotension, which means when a patient stands up, they feel lightheaded and dizzy and will absolutely fall over. I don't know if you've seen this yet in the hospital, but it does happen. Be very careful with your patients who are on these meds, especially the stronger ones. C, cholesterol targets. We want to keep the LDL. We want to get a 50% reduction from baseline. So when they come in, their LDL is wherever it is. We want to bring it down by half if we can. Usually these numbers are very, very high. And I'm not going to lie to you right now. I do not know off by hand the cutoff for an LDL, but I do have a video on it in which I looked it up and talked about it. So feel free to hang back there or just Google it. Everybody can Google. So ABC or D is drugs for cardiovascular risk. I talked about this a little bit already because we talked about what kind of meds maybe would be best. We talked about how angiotensin 2 can contribute to diabetes type 2. So you see here an ACE inhibitor is one of the first line kind of treatments. That's because it takes care of your hypertension. It takes care a little bit of some of those other diabetic factors. And then, then people will also usually be on statins, which I talked about in the video on coronary artery disease. And then ASA, obviously, and these we will talk about a little bit later, so I'm not going to go through them right now. And then E, exercise goals and healthy eating. 150 minutes of moderate to vigorous aerobic exercise a week. I hate going through these because I feel like it's really tedious, but then they always show up on the test. These and diet questions. Having to know how much potassium is in a green leafy vegetable, or honestly, I just let myself lose those questions every time. I refuse to memorize what is in each. I did not study nutrition for a reason. I don't enjoy it personally. So anyway, exercise, 150 minutes, moderate to vigorous a week. Usually that's about 20 minutes a day, 2 to 3 times a week with resistance exercise. And then the healthy diet. Really your big issue for here is having low cholesterol and low carbs, right? Because carbs are turned into glucose. So that's really your big kind of what you see. Screening we talked about earlier, but you want to have an ECG every few years. The foot stuff we'll talk about later. We'll talk about kidney, we'll talk about retinopathy as well. Smoking cessation is huge. I cannot emphasize this enough. Smoking cessation can actually reverse some of the damage that's been done to receptors. At least some studies are showing that. And then self-management. This is just about, those nursey questions about setting goals and assessing for stress and mental health. And this is kind of the fluffy stuff you should be able to get on a test with no problem.